J-Rhythm study is a Japanese rhythm management trial for atrial fibrillation. Actually, this is the first large-scale study conducted in Japan in the field of arrhythmias. Not only it is the first one, but also it gave us an important message, which I'm going to tell you later. J-Rhythm study started in the year 2003 and ended in 2008. Some of the results have already been published. But remember that in the year 2002, the results of the AFFIRM trial have been published. The AFFIRM trial is one of the largest trials in this area, comprising 4,060 patients with atrial fibrillation lasting 6 hours or longer. And importantly, about 70% of those patients had persistent atrial fibrillation. And this study compared rhythm control strategy versus rate control strategy to look at the total mortality. And they concluded that management of atrial fibrillation with a rhythm control strategy offers no survival advantage over the rate control strategy. The question remains whether one can pick any of these strategies to all AF patients without further considerations, and more importantly, whether the patient feel happy with this strategy. It is important to notice that in the AFFIRM trial, there were a significant number of crossovers, either from rate to rhythm control or rhythm to rate control strategies. Such frequent crossovers denote that patients are sometimes intolerant of the assigned strategy. The rate and direction of crossover may be vulnerable to the characteristic of patients and the type of atrial fibrillation. With this background, we have conducted J-Rhythm study, which is a randomized multicenter study comprising 182 centers. The primary endpoint was a composite of total mortality, symptomatic cerebral infarction, systemic embolism, major bleeding, hospitalization for heart failure requiring intravenous diuretics, and importantly, physical and or psychological intolerance requiring switching the treatment strategy was also included in this primary endpoint. Secondary endpoints included quality of life scores, which was atrial fibrillation specific we have designed, and comprising frequency of symptoms, severity of symptoms, and also anxiety or limitation of daily activities. And also efficacy and safety of drugs were one of the secondary endpoints. So this is the outline of J-Rhythm, which comprises 1,065 patients. The average age was 65. 885 patients had paroxysmal atrial fibrillation on the left, and 180 patients had persistent atrial fibrillation on the right. Paroxysmal atrial fibrillation was defined by atrial fibrillation lasting shorter than 48 hours, while persistent atrial fibrillation was defined lasting longer, but shorter than 1 year. Those patients with paroxysmal atrial fibrillation had to have sinus rhythm at baseline, and those patients with persistent atrial fibrillation had to have atrial fibrillation at baseline. And those patients were then randomized into either of rhythm control strategy or rate control strategy, and were followed up for the average of 585 days. And this slide shows the drugs used for initial therapy for rhythm control in the upper and the rate control in the lower panel. In the lower panel, as you can see, that in patients with paroxysmal atrial fibrillation, beta blocker was most frequently used, about 51%. Whereas for patients with persistent atrial fibrillation, digoxin was most frequently prescribed. When you look at the upper panel, you will notice that there were a wide selection of antiarrhythmic drugs available in Japan, and each attending doctor selected one of these drugs according to the Japanese guideline for atrial fibrillation management. About 1/3 of patients with paroxysmal atrial fibrillation received pegcetacoplan, which is a class 1C drug, sodium channel blocker, which was followed by cybenzolone and propafenone, disopyramide, and so on. But for patients with persistent atrial fibrillation, again, pegcetacoplan was prescribed most frequently, but was followed by disopyramide and bepredil. Bepredil is a unique drug which has recently been proved to demonstrate significantly high conversion rate for patients with persistent atrial fibrillation after taking drugs every day for 4 to 6 weeks. That is somewhat specific to Japan. This is the efficacy of the drug shown as the percent sinus rhythm recorded at each visit to clinic. On the left, you will see in patients with paroxysmal atrial fibrillation, the rhythm control strategy yielded a high maintenance rate above 80% over 2 or 3 years. However, the rate control strategy yielded a progressive decline in the maintenance of sinus rhythm. On the left, as you can expect, in patients with persistent atrial fibrillation, the maintenance rate was significantly lower, particularly in those receiving rate control strategy. And this is the slide showing the primary endpoint. The event-free survival in patients with paroxysmal atrial fibrillation was significantly different between these two strategies. Rhythm control group had a higher event-free survival than the rate control strategy. And for patients with persistent atrial fibrillation, the pattern was somewhat reversed, but did not reach statistical significance. P was about 0.08. When we look at the more detail about the components of the primary endpoint, this is the hard endpoint, including death, stroke, embolism, bleeding, and heart failure hospitalization. There were no significant difference between rhythm control strategy and rate control strategy in terms of event-free survival for those patients with paroxysmal and persistent atrial fibrillation. However, when we look at the soft endpoint of intolerance to the assigned strategy, the rhythm control strategy yielded the higher event-free survival in those patients with paroxysmal atrial fibrillation. However, in those patients with persistent atrial fibrillation, although the pattern was somewhat reversed, did not reach significant statistical significance. So this means that the intolerance to the assigned strategy was found in about 16% in rhythm control group in paroxysmal atrial fibrillation compared to 11% in the rate control strategy. when we look into the detail of this reason for intolerance, the majority of the reason was uncontrollable symptoms. And other reasons included hesitation against electrocardioversion, anxiety over drug adverse effects, and so on. But in the rate control strategy, uncontrollable symptoms were the major reason to cross over or intolerant to stay on that same strategy. So we can summarize that the mortality and morbidity were not affected by the rhythm versus rate control strategy in both patient groups of paroxysmal atrial fibrillation and persistent atrial fibrillation. And secondly, in a subgroup of patients with paroxysmal atrial fibrillation, a significantly greater number of patients receiving rate control strategy became intolerant to remain on the same strategy, mostly due to uncontrollable symptoms. So we conclude that more attention should be paid to quality of life of patients in selecting rhythm versus rate control strategies. Thank you very much.